welcome everybody, dear colleagues, dear experts, and everybody who are interested in the e-health governance. I am Kerti Merimaa from Estonian Ministry of Social Affairs, and I am very happy to welcome you to our informative meeting. And thank you for being interested in the e-health governance topic. Today's session is the second one in series, and it's part of the activities planned to support the Estonian e-health governance model project, where we, with different Estonian health stakeholders, together with Minister of Social Affairs, Ernest Young, European Commission, and international experts from EHTEL, European Health Telematics Association, are collaborating to redefine the Estonian e-health governance and to renew its structure, processes, and KPIs. And as part of that, to design a more informed governance model, our colleagues from EHTEL have prepared overviews of e-health governance of 7 countries. Today, we will hear about the e-health governance in the Catalonia area of Spain. And without further ado, I give word to Siim from Ernest Young. He can also say his welcoming words. Thank you.
Thank you, Kerti. Maybe just a small remark that the main idea of looking those country reviews is to gather some interesting lessons learned and information and pros and cons from different countries, their practices of e-health governance, in order to utilize this experience in Estonian model. Otherwise, I would give the word forward to Tina. Catalonia will be the first country. Thank you.
Thank you very much, Siim, and good afternoon to everyone. First of all, the reason why we chose Catalonia is because in Spain is one of the regions where the level of provision is more fragmented, and therefore the challenge from an e-health perspective is higher. And on the other side, in Catalonia, there is a long tradition on e-health development that has been featured in different places. So even if it's a region of Spain, it has full jurisdiction for healthcare organization and for e-health organizations. So in practical terms, is acting like an independent country. And I'm not entering here into politics, but just because every region in Spain has the jurisdiction of developing their own e-health systems and infrastructure. Another topic is how these different regions interconnect between them to have a global view if you are moving around Spain. But if you live in a region and you are in the region, then the full jurisdiction is for the regional government. So having said so, I would like first to provide a methodological explanation of how the country cases have been developed. We have followed for each country report the same methodology, and this is based on the governance framework developed for the digital health governance. This is published by the Asian Development Bank, and in a nutshell is what you can see on your left side, is how you govern and what you govern. And in terms of what to govern, we have identified 3 main pieces. One is the e-health infrastructure and service. The second is information health data, and the third one is capacity skills evaluation methods and tools. On the how to govern, we are following the same path. So we are looking how the different stakeholders, the governing actors, plan and strategize, develop and maintain, monitor and evaluate, and stimulate innovation. And this is what I would like to cover in the presentation and say will happen with the case presented by Luke from the Netherlands. The first element is to put you in place. I know that the health system in Catalonia differs substantially to the health system in Estonia, because we are more based on an NHS type system rather than a health insurance model, but the similarities are more than you can anticipate. We have a layer of planning based on the role of Department of Health and the Department of Social Affairs, which are two different departments, and this is probably the first difference comparing with Estonia. But we have a very important and key role from what could be the Estonian Health Insurance Fund in Catalonia, that is called Catsalut. It's the public health insurance who is procuring all services from primary care to extra hospital care. Not public health, not social services, because this depends directly from the Department of Health and the Social Affairs. So I would like to stress the role of Catsalut as the payer, the procurer of services. And then we have, as I said, a fragmented landscape of healthcare provision. There are many different providers. There is a big one that is public, is the Catalan Institute of Health, which has played a very important role in the development of eHealth building blocks, but it's not the only one. And just to give you an example, in primary care, 80% of primary care teams are managed by the Catalan Institute of Health, while the remaining 20 are other organizations. And in hospital care, 20% of hospitals are managed by ICAs, while the 80% remaining are managed by different types that can be public enterprise, consortia, foundations, so a diverse nature of organizations. They are organized in the network of providers, which is a virtual organization that is contemplating all these types of providers. So these are the two main differences. The difference between MOSA and the Department of Health and Social Affairs, similarity with the role of the Health Insurance Fund. And we have eHealth Competence Center, Catsalut Social, that could be compared with TEHIC. Actually, I put it here just to give you these similarities with your health system, that Catsalut would be a sort of TEHIC, but this has changed over time, and you will see the situation. What I will present is the situation as it is now, and it has been in the last 3 years, but we have evolved over time in how the eHealth is governed and organized in the region. And I will point out which were the reasons why we changed to the model that I will be presenting right now. So the first element is that we started very long time ago in terms of investing and developing the eHealth infrastructure. And this was mainly a joint effort of the Department of Health, the Health Insurance Fund, and the healthcare providers that, as a result, produce an integrated health information landscape that allows healthcare providers to exchange information. So it doesn't matter where you are visited, in a primary care center managed by one organization or another organization, this information will be shared with the shared electronic health record. All health providers, they use electronic medical records, so they are fully digitized. In primary care, more than 90% of primary care teams, they use the same system that is called ECAP. And the reason why is because they are mostly managed by this big public enterprise, Catalan Health Institute. And the elements of interoperability that emerged some time ago now, because more than 10 years started all this health information exchange that materialize in the shared electronic health record and an interoperability platform that exchange information. And this is what is bringing integration between different providers. So it's a very good lever for integrated care and coordinated care. In terms of prescriptions, fully digitized since 2011. For medical image, fully digitized also from 2010. And the other element is how patients access their information, and this has been evolving over time. Now it's working really well. There is a personal health record. All citizens have access to this personal health record. It's called My Health, La Meva Salut in Catalan, and is becoming very useful. For instance, now in the COVID time, you are vaccinated, you need your certificate. You don't have to go to get a copy of your certificate. You just log into your personal health record, go to reports, and download your certification of vaccination. So really convenient to reduce the burden of work at front desk, and also allowing patients to move around with access to the information. In terms of the building blocks, and we have to start from the ground. So the first ones that started the digitization were the healthcare providers, because they had the autonomy to choose their own electronic medical records. This was very good to accelerate adoption, but it was challenging over time, because it meant that many different providers used completely different systems that they didn't talk to each other. In the case of primary care, the problem was not that critical, because the monopoly, let's put it this way, of this big public enterprise, so 90% of the market of primary care records is only one primary care record, and then there is a remaining 10% that use different solutions. While in hospital care, you have completely crazy landscape. Actually, we have 65 acute hospitals and 29 different hospital information systems. So this was a challenge that was alerted in 2005 when they started to develop the shared electronic health record, and it was solved through this solution, the shared electronic health record, and the interoperability platform to connect providers. So what providers are doing, they are using their own, but this system is automatically sending the information to the shared electronic health record. So the healthcare professional that can work in different places, they will always have access to the information of the patient through this shared electronic health record. So continuity of care is ensured by this shared electronic health record. And this is fully deployed, and at present, not only primary care and hospital care, but also long-term care and mental health, they are connected to this platform and exchanging information. And the process now is to include information from the social services. And actually, there are different results of this connection that helps to coordinate care, like individualized and personalized care plans between different providers, a primary care doctor, a specialist in the hospital, a social worker from the social services, accessing the same information and getting joint decisions through this system. In terms of personal health, the access for patients is through this system, My Health, and this is provided by the Health Insurance Fund, Catalonia, which I will explain now with more detail. But this is, in a nutshell, the full picture of the spectrum of different systems. The advantage is the interoperability and the shared electronic health record to ensure coordination. The problem is more on this side, on the hospital side, many different systems. So, for instance, if you want to introduce an innovation and one of the systems has already this innovation, to spread the innovation, you need 28 different evolutions of the systems to get this innovation in place. So there is a work now to try to reduce the number of hospital information systems to reduce this excessive cost of maintenance and developing new features. In terms of stakeholders, and here there is not a full list, are those that are more involved in the decision making, but we could add here, for instance, the professional associations, the scientific societies, even the unions play a role. But in terms of who are the key players in decision making, we have the Department of Health, the Health Insurance Fund, the eHealth Competence Center, TIC-SALUD, the Agency of Quality, which plays a very important role for the reuse of data, secondary use, big data, and for research and innovation. The healthcare providers, together under this network SysCat, but some of them, like the public healthcare provider, this is alone has already a lot of influence and power in decision making. Social service from the Department of Social Affairs, and then two centers, the technology centers for security and information technologies. We will put this now in place. You can see the fragmentation of many different actors playing a role, but the important is how it is right now. And here is one of the key messages. At the beginning, eHealth was considered a marginal matter. It was not that strategic, and that's why it was concentrated more on this eHealth Competence Center that started in 2005 and did a lot of work in terms of developing the shared electronic health record or the personal health record. But over time, eHealth has become strategic. So the decision making and the critical governance functions have been transferred slowly, but in a determined way since 2015 to a new role that is a role that doesn't depend of any of these organizations, is connected with Department of Health and the Health Insurance Fund. That is the General Coordination of Health ICT. So this is one person that is responsible to coordinate all the decisions that are done in the domain of eHealth, taking into account the different aspects of providers, the quality agency, the Health Competence Center, technology centers, but basically connecting the Department of Health Planning with the implementation done by the Health Insurance Fund. The mission to improve population's health and quality and efficiency of healthcare. How this general coordination of health ICT works. It's appointed by the Department of Health, but is sitting in the Health Insurance Fund and has one eHealth office that is a team of staff that is sitting in the Health Insurance Fund, but some of them, they are still sitting in the Catalan Health Institute, in the public healthcare provider, and some in TIC Salud. The important thing is that it's centrally managed by the General Coordination, the eHealth Office, and it's a structure with different areas. You can see here the list of areas, how the eHealth Office is a structure, a technical one, a functional one that is developing the front end of the solutions, and this is led by a clinician. The analytics area, a catalogs and standards area, technical communication, a mobility area, information security, data protection, administrative, the primary care system area, interoperability, and image diagnostics. All these areas that are like departments of this eHealth office are managed by the General Coordinator of Health ICT, and they are developing the central eHealth building blocks that are those that are developed at central level, the shared electronic health record, the interoperability platform, the personal health record, and the primary care electronic medical record. The only exception would be the primary care medical record, because it should be more on provider side, but because it's 90% controlled by this institution, it's already centralized. So all the developments are centralized in this eHealth office. One of the key planning documents of the General Coordinator was in 2018, the Health Information Systems Master Plan. And this was commissioned actually by the Department of Health Health Plan from 2016 to 2020 that said that a Health Information System Master Plan was needed, and asked the General Coordinator to develop this master plan. There is now a full English translation of the master plan that is available under this link. There is the executive summary, but the full text already here. And the plan, what did was an analysis of the situation, identify the burning issues, particularly the fragmentation in hospital care and the lack of a fully interoperable electronic health record, because the shared electronic health record is sharing documents, is sharing data of specific aspects, but it's not sharing data systematically. And the bet of this master plan was to focus on data and the information system architecture needed to exchange this data at the speed that can be useful for daily decisions, but also very useful for planning purposes. And one of the first steps was to develop this electronic health record that is called HES. This is under development, and it's planned to substitute the primary care electronic medical record. So what we are doing is basically upgrading the primary care medical record into the national electronic health record for the whole population. And then the remaining hospital information systems, they will be connected with this, and they will ask to exchange the data in a way that will share the same data model, a common data model, to accelerate this use of data. Instead of going through all the functions for governance in different slides, I have tried to summarize them all in one slide because this will help us to give us a visual look of who is doing what. So you have here in the first column the key actors: Department of Health, the Health Insurance Fund, the Health Competence Center, the health and care providers, so the more than 100 different healthcare providers from hospital, primary care, long-term care, and mental health, the quality agency, and these technology centers that are supporting the development of the eHealth building blocks. In the first column on planning and strategizing, who is doing the planning and strategizing? Actually, it's the Department of Health setting the health plan, and specifically with a chapter, a strategic axis on digital health, which one of the results has been this master plan on health information systems. So that the planning is under the Department of Health, but they are not alone, and actually they count very closely with the Health Insurance Fund to implement what is in the plan through the service contract that the Health Insurance Fund has with every single health provider, and also specific action plans that they deploy for specific activities. In this planning process, the rest, they play a secondary role. Salud is consulted. The healthcare providers, they have autonomy, they keep autonomy to develop their local system, so they can strategically plan how they will develop their own e-health ecosystem, but they should, and it would be preferable to be aligned with what has been set forth by the Health Information System Master Plan. In the case of the Quality Agency, they have a special mission on data reuse for research and innovation, so they plan this domain of big data. And technology centers, they are just consulted. So here, I would say the weight is over the Department of Health, and in a second place, the Health Insurance Fund, plus the local planning of healthcare providers. In terms of funding, Department of Health steps back. Here it goes all the weight for the Health Insurance Fund, and they fund the local providers through the annual budget, and they invest part of this budget in ICT. The average IT spending is between 1% and 2%, but the larger providers, they are spending up to 5% of their budget in IT. But to develop these building blocks that they are already in place, but they have to be upgraded and renovated, the shared electronic health record, the personal health record, the interoperability platform, and so on. There is a multi-annual funding program to develop these building blocks. Salud here is not playing a critical role, but for the innovation projects, they have a specific funding, and they participate in competitive European projects to raise funds. Same happens with the Quality Agency, with Aquas, and the technology centers, they support in the procurement process. When this is already funded, or funding is secure, then the development and maintaining goes to Catsalud through the eHealth office, because it's mainly situated in the Health Insurance Fund premises, and it defines interoperability standards, maintain these building blocks, and develop the new ones. Local providers, they keep developing their own electronic medical records, but adapting to these new requirements. Salud is involved in pilots. Aquas develops the big data project, and the technology centers, they support the development and maintenance. In terms of monitoring and evaluation, here we have two big elements. One is these central blocks, they are monitored by Catsalud, and there is evaluation of digital services, the use of specific telemedicine programs that are incentivized through the service contract. But in terms of which is the impact, the overall impact in the health system, this is a role that the Quality Agency has. They do annual evaluations of activity and performance of healthcare providers, but eHealth is still not a very important piece of these annual evaluations. But they have this request of doing these annual evaluations, and they are published in a results central. Local providers, they do their own monitoring of digital health service infrastructure, and the technology center supports in monitoring and the infrastructure. Finally, who is stimulating innovation? Who has the mission is Tixalut. That's why they were born to promote uptake of new digital solutions. And through this earmarked funding, they do some pilots to for those services that are still not mature to be fully deployed, and they are experimenting with these elements. But they principally scan how is the market and which are the innovations that the healthcare providers are bringing into the healthcare landscape. But Catsalut has a very important role in stimulating too, because what they do is through the service contract, they can introduce new incentives that will help providers to adopt these innovations. And actually, there is a group that works in the Agency of Quality on innovative public procurement, that they develop goals for this and they participate in European projects. And some of them, they are channeled through the service contract of Catsalut. The Department of Health includes new actions in the health plan, and the technology centers, they just are consulted in this stimulation innovation process. So I hope that this has summarized the whole spectrum of roles and actors, what is doing what. And if you trace a line between who is paying or planning and playing and who is providing, which would be this line, you can see perfectly how the priority goes from Department of Health Planning, the Health Insurance Fund, funding, developing, and monitoring and evaluating. So here you can see a clear key message that the current governance model is centered in the Health Insurance Fund, in Catsalut, because eHealth has become central to healthcare operations. And Tixalut remains as the innovation promoter of eHealth. And from a secondary use, we have the quality agency that is playing an important role in the development of this big data project, and they have these annual evaluations that provides transparency to the system. Finally, what went well and what went wrong in this process? I would highlight some elements of success. The first is that it was an early adoption of eHealth in the first wave of healthcare digitization. And one of the early wins was the consolidation of the primary care health information system, basically due to this advantage of having one organization dominating 80% of the market, and they could invest enough money. And I'm talking about the year 99 and 2000, so it's a very long time ago, but this was like the backbone of the eHealth system that was put in place really early on. From there, due to this fragmentation, the solutions that were adopted, the shared electronic health record and the interoperability layer, together with the personal health record, I think they are successes that we have seen the effects a bit later compared with the primary care solution, because this was fully deployed by 2015. And in the case of the personal health record, has been renovated recently, and now it's really a very good service for citizens. This has helped to drive the system to better coordination and integration, and developing this person-centered care approach that allows citizens to access health information, not really health data, it's more health information at the moment, but the plans are to provide also access to the data that could be downloadable. What could be done better? And here the main point is the fragmentation of hospitals, the number of existing electronic medical records. This is very costly for the system because you are duplicating the same effort over again. And the need of concentrating this in central solution is what is being worked now, but it's very difficult once everyone has already taken the decision of adopting one system. So it will take at least 10 years to rationalize and harmonize the landscape of hospital information systems. The other element to improve is related to this big data project, and the reason why it didn't work well is because it was politicized. At the beginning, it was considered that this project was done to sell data to commercial entities, and this was stopped. So it has to be completely redone, and now maybe now the problem is that it's too much protected, and only researchers can access this data following a very strict protocol to access the information. So here there is still room for improvement, particularly because the trends in Europe are to open up these information troves to improve and accelerate innovation and research. And finally, this is an element on governance. We have moved to a marginal role of eHealth to a central role of eHealth, but in this process from the margin to the center, maybe we have lost some elements of participation. So there is this general coordination that is interplaying with the different actors, but there is not a formal and institutionalized participatory body that will help to capture all the views of the health system landscape. So this will be the final element that should be addressed in the coming times, but because there is a strong emphasis on developing these central building blocks, participation has been more in the site and has been the stress on execution and deployment of the central solutions. I stop here. I thank you very much, and I give time for questions and comments if there are.
I have a question, Tino. On one slide where you were listed horizontal and thematic organizational areas, I cannot find here an architecture. Is it somewhere hidden between technical and functional area, or how it is governed?
The one on architecture is not strictly an area. It would go to the technical, and it's connected with the services that are providing these technology centers that belong to the government, and they provide all the IT infrastructure. So, but the area that would deal with this is the technical area.
Yes, thanks. Because sometimes the architecture can be handled from different angle points, whether more technical or from the business point of view. Who is responsible for which part of the functionality or data. So what I'm keep in mind is more like a high-level architecture. For example, if we need to develop some new functionalities which is relevant for all healthcare providers, then whether to develop it in the healthcare provider systems or to resolve this problem on the central level.
In this case, it's resolved in the central level. It's not. They are not doing anything at healthcare provider level, because what they have to do is these central building blocks: the shared electronic health record and the personal health record, and so on. Except with that's why I gave the exception of the primary care information system. This is already absolutely at healthcare provider level, and it's developed and maintained by the eHealth office. It was originally at the healthcare provider level, but has been transferred to the health insurance fund. So the health insurance fund has bought the solution and is responsible for maintaining the solution and evolving this solution as it is in the master plan.
Thank you, Tino.